Okay. Good morning, everyone. Thank you for coming. So I left this talk actually more for planning and sizing for AAA, really for straightforward aneurysms, and this talk is really geared more for the trainees in the audience. So I'll try to keep it brief and simple. I have no relevant financial relationships to disclose. Goal is really learn the basic tenets of EVAR sizing and give an overview of the commonly used EVAR grafts. So first step is you identify a patient with an aneurysm, you obtain a CT angiogram. Ideally, you plug this information into a reconstruction software to obtain center line measurements, both for diameters and lengths. This can also be done using axial cuts or axial images with less accuracy. There are a lot of things that need to be noted. The location of all your visceral vessels, location of any renals, accessory renals, lowest renal, the IMA, whether it's patent or not, if it's large. I often will consider embolizing if it's large. The size of the aortic bifurcation, your iliac bifurcation, and then determining diameters and lengths. Ideally, we need the infrarenal aortic diameter, so the iliac artery diameters. So those need to be determined where you're basically going to be sealing the aneurysm proximally and distally. And then determining the length of the seal zone. Ideally, for the proximal neck, we like to see 15 millimeters. For the Endurant, that can be as little as 10. For Ovation, you can use as little as 7. But ideally, longer is better. For the iliacs, centimeter to 2 centimeters, depending on the device. So the proximal landing zone, distal landing zones. Again, determining the length of those landing zones. And then determining the diameters of your infrarenal neck, your iliac arterial diameters. So those are going to be determined. And again, this can be done through axial imaging or centerline. Of course, centerline imaging is preferable. And then, of course, you need to obtain a number of lengths. Lowest renal to the aortic bifurcation is an important length. If we're doing a more complex reconstruction, then you need to note the diameter from your proximal seal above, say, the celiac or wherever you determine your proximal seal to be, down to your first visceral branch, and then the distance from each visceral branch down, along with clock positions for each of the visceral vessels, along with the diameters of each visceral vessel and the length of the seal within each visceral vessel. So those things go into play when we're thinking about more complex aneurysm repairs. But for a simple, straightforward EVAR, the distance from your lowest renal down to the aortic bifurcation is very important. And then the distance to your left hypogastric, and then the distance down to your right hypogastric. All those measurements are very, very important, and for most of the devices, or all the devices, you can pretty much determine what size device you're going to use from this information. Diameters. Ideally, diameter measurements should be done using centerline, but if that's unavailable, using axial imaging is okay. Generally, you want to measure along the shortest axis, so that way you don't get fooled with a larger diameter due to tortuosity or angulation. So in this patient here, we're measuring, approximately 21 millimeter aortic neck down to where it starts to dilate, where it eventually gets to around 24. So when we're determining the size here for diameter, we're looking at a 21 millimeter aortic neck, and so we'll base our size off of that. We do something very similar for the iliacs, and then in terms of lengths, again, can be done using centerline, which is, in my opinion, the easiest way to do it. Looking at path length down to the bifurcation, path length down to the hypogastric, but it can also be done based on the slice location on an axial image. For example, this is 356, and I'll kind of go through this. The next image is 466, and so on and so forth. So if you look, 356 to 466, so you're looking at 110 millimeter length, and so those lengths can then be determined. Other information that's very, very important: neck calcification and thrombus. degrees of tortuosity, as well as angulation. Access vessel diameters are very, very important, especially when it comes to device selection, and the use of adjuncts such as conduits, etc. Looking at the common femoral artery, determining if it's suitable for percutaneous access or cut down. And then oversizing. Too little is of course no good. If you look at this device, this is undersized, and you can see that there's a clear gap between the aortic wall and the stent graft. That's going to result in an endo leak. Or too much oversizing. That also is bad. You can get infolding of your graft, which also can cause an endo leak. So typically for the proximal aortic diameter, you want to oversize around 20%. For the iliacs, somewhere between 10 and 20% is acceptable. Now, just to go through some of the commonly used devices. So for Cook, there are sizing sheets that can be used. You take the measurements that were obtained previously that we talked about, the diameters and lengths. You can plug those numbers into a worksheet and then determine which graft you're going to use. The Cook graft is nice in that you can actually get a main body of varying lengths, which allows some flexibility in what can be done in the future. So if for example, you feel the neck above the renals could potentially be hostile or may subsequently need a fenestrated device, choosing a longer main body could be useful. If you have a long aneurysm, this could be useful. Also, if you want to position your bifur in an ideal location to cannulate the gate, you can basically choose a device length that's appropriate. All the devices have tapered, straight, flared configurations for the iliac limbs. So this is the Cook device. Based on the device, the measurements that we took, we're looking at a 21 millimeter neck, 13 millimeter iliacs. So we're basically going to pick a, if you look at the sizing chart here, you've got a 21 millimeter proximal diameter, so you're going to go with a 24 millimeter device. So they have the sizing charts for each of the main devices that are available today. And so you basically just go through that, go through the sizing sheet. With Endurant, you have two configurations, Endurant 2 and the Endurant 2S, which is the main device currently being used. The length from the top of the device to the bifur is fixed around 5 centimeters here, 5.5 centimeters. So you don't have that flexibility in terms of the main body length, but this allows a lot of flexibility in terms of iliac length determination. So these are some of the sizes. And again, the sizing sheets will have all this information. Determining the French size. This is very, very important for any device you're implanting, so that you basically look at this and make sure that it will comply with the access vessel diameter. So that's of course very, very important. And most of the devices currently available go from anywhere from 20, being able to accommodate 20 millimeter necks all the way up to 32 millimeter necks in the majority of cases. Again, this is all for the Endurant. All the devices have proximal and distal extension pieces that can also be used. Again, reference these sizing charts. This is the Gore. Again, devices anywhere from 23 millimeters to 35 millimeters, being able to accommodate neck diameters anywhere from 19 to 32. And then again, same, you're going to use the sizing charts, determine your diameters, determine your lengths, and then make sure that the French size is compliant with the access vessels. The Endologix device is different than the three previous devices described, in that it's a device that sits on the aortic bifurcation, and it's built slightly different in terms of how you select. And for the contralateral limb, generally can use just a 7 French sheath, 16 French sheath on the ipsilateral side. First step, pick your proximal endograft size and length. And then you're going to pick your iliac limb, and then you're going to pick your bifurcated stent graft. Again, being able to, what's different here is that you're going to pick a main body that's going to be smaller than your proximal piece, so you can seal the main body with the proximal piece. And then it comes in a number of different lengths. This can actually be useful when treating things other than aneurysms. So if you're treating an aortoiliac occlusive disease case, you can choose, say, a 25 millimeter device with a shorter main body. This is also useful if you have a short distance from the renal down to the aortic bifurcation. you could basically customize this a little bit more in terms of dealing with a short distance from the renal down to the aortic bifurcation. Also, when dealing with very tight aortic bifurcations, this can be helpful. And then, of course, choosing any iliac extensions. The Ovation is also novel in that you have a sealing ring, an O-ring, that's going to be filled with a polymer. And so unlike the previous devices which rely on self-expanding stents with radial force, this basically relies on the seal of this O-ring in the proximal neck. This can handle necks as short as 7 millimeters and has some advantages in that it's the smallest French size available for the current EVAR devices available in the United States. So for small access patients, this could be a useful device. And again, very similar in determining the lengths and diameters, using the sizing sheets as appropriate. And that's pretty much it. To open the floor to any questions.